may I call upon Robert Linkins, who is the Chief, Accelerated Disease Control and Vaccine Preventable Disease Surveillance Branch at the Global Immunization Division at the U.S. Federal Center for Disease Control in Atlanta. You have the floor.
Good afternoon. Excuse me. Good afternoon, and thank you very much to the conference organizers for making the invitation for me to be here today. It's really a very, very great honor to be here and represent the U.S. Centers for Disease Control in Atlanta. I also want to thank the cooks because I thought lunch was just fabulous, but I'm comparing it to the Italian food we get in the U.S. So, but I think it was very good, so thank you. I have been at CDC now for almost 30 years, and most of that time I have been working in the field of vaccine-preventable diseases, specifically polio eradication and measles and rubella elimination. And whilst I was tasked today to speak about surveillance, given my background, I'm going to be putting that in the context of measles. And I hope that I am not going to be repeating too much of what Dr. Celentano said this morning in such a very, very wonderful talk. So let me get started. Just wanted to set the stage for surveillance. We see surveillance in terms of three different stages. The early stage of surveillance where an immunization program is really worried about control of disease. And in that era of surveillance, the purpose is to monitor incidents and identify high-risk populations, and then to follow up that identification of populations with immunization strategies to mitigate their risk. And you see that if you can see the light yellow line, you see that that's when we really see very high peaks of measles, as well as intermittent outbreaks that are expected when you have low vaccine coverage. Moving on to the second stage of surveillance, outbreak prevention, really the purpose there is once you get high enough coverage, what you want to do is you want to describe the changing epidemiology of the disease. You want to identify high-risk populations, and you want to be able to predict and prevent outbreaks. And now you're moving from a surveillance system where you're only reporting the number of cases of disease that a particular area has to a situation where you actually are line listing cases that occur in outbreak situations. And then the final stage of elimination, which I think is relevant for measles and rubella elimination in Euro right now, is the instance where you're actually doing case-based surveillance, where you want to identify every single case of measles or rubella, as the case may be, or any vaccine-preventable disease that's in elimination mode. And then you want to collect specimens for genotyping, because you want to not only identify the case, but you want to ensure that you know what sort of virus is actually circulating in your community. Because the closer you get to elimination, we see this very clearly in polio eradication, the different virus strains should decrease in number. So instead of having 24 strains of polio virus circulating globally 5 years ago, we now have 2 or 3. So that's very exciting, and it tells you that, yes, indeed, you are approaching elimination of a virus. So that's the exciting time. As you all know, before I do move on, as you all know, Euro does have an elimination goal of 2015 for measles and rubella. This is the second goal that you've had. You had a 2010 goal that was not met. And the tea leaves are telling me that you're not going to make 2015. So there's a lot of work to do. Case definitions are a critical part of surveillance. It's critical that case definitions are standardized. I've worked in a number of countries around the globe, and it seems that everyone feels that when defining their cases of a particular disease, it's their time to be creative. And what might be measles in Vietnam is not exactly measles in Cambodia. And that means that over time, It's very difficult to track progress and to really know if cases are going up or down, or whether you're looking at the same thing, whether when you go out and do outbreak prevention, you're really using the proper vaccine. So without standardized case definitions, it's really impossible to get a grip on what's happening both within a country, because they can vary within countries as well as between countries. In the WHO Euro guidelines, they have standardized their case definitions, and I understand these have not been adopted by all the countries in this region. And these case definitions are shown on the slide. I'm not going to go through them because that's probably way too much detail. As we have with most diseases, we have a suspected case of a disease X. We have a laboratory confirmed case. And for measles, that would be one of the 4 criteria following. You need a serum specimen to confirm measles. And then we have something called an epi-link, or an epidemiologic linkage to a laboratory confirmed or an epi-linked case. And then finally, we have something called clinically compatible, and this is a case that was not adequately tested by the laboratory. And really, the importance of clinically compatible cases is it's one way that we measure the quality of your surveillance system. If you've got a high number of clinically compatible cases, it means you haven't done a very good job with your surveillance system, because you haven't appropriately confirmed those cases using laboratory or epi-linkage. So this is one way we can tell if not only if your numbers are going down, if the decrease in your numbers is actually real or not. There are actually 3 that I know of, 3 recommendations that have been made. The Millennium Development Goal number 4, reducing child deaths by 2/3 among less than 5-year-old children. That's relevant to our measles elimination target here in the region. MCV1 coverage, that's measles containing vaccine 1 coverage, first dose measles, is an indicator for MDG4. So we are measuring progress in the region and in the globe by tracking the coverage of MCV1. The Global Vaccine Action Plan has the goal of eliminating measles in at least 4 WHO regions by 2015 and eliminating measles in 5 regions by 2020. And then SAGE, the Strategic Advisory Group of Experts on Immunization, has measles a milestone of achieving MCV1 coverage of 90% nationally and 80% in every district. And then finally, decreasing incidence to less than 5 cases per million. Here's a map of the globe where we're at in terms of establishing measles and rubella elimination targets. The red numbers in the Americas as well as in Euro indicate rubella elimination goals, and the lighter orange are the years that are targeted for measles elimination. And you see that all regions have measles elimination goals, which in my mind translates to a global eradication of measles goal. And then 2 regions at the moment have rubella elimination goals. But there are a number of regions, one of which I'm going to tonight, that is very involved in considering whether they will adopt a rubella elimination goal. So it's very exciting times for the measles rubella program globally. The regional committee in Euro provided guidance on eliminating measles and rubella by 2015, and as part of that guidance they said it's time for member states to start conducting case-based surveillance. That needs to happen in every single member state, and that should be that should include a collection of adequate laboratory specimens that are tested in accredited laboratories that can confirm cases based on a lab specimen. Reviewing your elimination plans to ensure that you've got strategies to immunize susceptible populations, and when and where and why you should conduct supplemental immunization activities. Another way of saying mass immunization campaigns like have been so commonly and effectively used in the polio eradication program. And then establishing national measles and rubella elimination verification committees, which are critical in finally at one point looking at your data or over a series of meetings and saying yay or nay the country has actually reached elimination, or actually these committees are regional in scope, so they look at the region together and say, yes, has Euro reached elimination or not? There's another set of recommendations. There was a global measles rubella strategic plan that outlines strategies to reach elimination. And the first strategy is to reach high population immunity. That's immunity between 92 and 94% of your population that has seroconverted to measles. And that's done with 2 doses of measles and rubella containing vaccines through either the routine immunization program, so that means reaching very high coverage on your measles first dose, as well as reaching very high coverage on your measles second dose. Measles isn't a vaccine that produces 100% seroconversion, so if you want 90% population immunity, you have to do higher than that in terms of your coverage to get that level of population immunity. So either through routine immunization or supplementary immunization activities, good surveillance, monitoring, and evaluation, outbreak preparedness, response, and case management, and finally communication to build confidence and demand, and finally research and development. And I want to say a few words about these last 2. This is from the conversation this morning. I was very impressed with the discussion and the presentations today, and sat there, found myself thinking that we really have, I mean, clearly one of the big issues here in the region is the issue of vaccine hesitancy. I think we have to concentrate both on changing the perception of the parents, but also the health care providers. And I think that's actually a point that's been made, but one that's often neglected. What I hear when I visit countries is, the parents need to, care for their children more, or we may have to make it easier for them to access vaccination. When in fact, when they do bring their children to clinics, the providers can often say, oh, he has a runny nose, maybe it's not time to vaccinate, let's do it next time. And then that child has maybe months of susceptibility and risk of immunization or vaccination. We see a lot of false contraindications, and I'm not sure that that we are really being creative in how we are using the information we have. An important tool that we used in the United States to increase immunization coverage when we were trying to rid the country of measles was we would send teams of public health technicians to clinics, and we would have them review records, and we would have them look for missed opportunities. And based on missed opportunities, we would actually have them sit down and train staff and teach them when it was appropriate to vaccinate children and what the appropriate contraindications were. They then went back a few months later and they did the same sort of assessment, and if they didn't see improvement, they had the training again, and so on and so forth. We also really relied on reminder recall. So when a child was due for an immunization, the parent got a phone call or a letter in the mail, much like you probably do here with maybe your dentist or your pet when it's due for a rabies vaccine. And then if the parent misses the vaccine, the parent is contacted again and again and again. I was just in a country in Africa where I learned that they send SMS messages to parents that don't bring their kids in when they're due for immunization. And to receive those SMS texts, the parents actually have to pay money to receive the text. If they don't bring in the child, they get another text, and they get another text, and they get another text. So it's actually a very interesting, I think this was unintentional, but it's a very interesting incentive that has been created to ensure that parents will be will bring their children in. I also wanted to say just a few words on research and development. I'm really delighted, John, with the emphasis that you've talked about in your talks, both this afternoon and this morning. And it seems like there's an awful lot of research being conducted in many different groups. And I think one great thing that perhaps we need and could flow out of this meeting would be some sort of research coordination where we got together and shared what research was being done and where the research gaps were. At CDC, we actually have a research solicitation process where we will fund proposals from people. This is a bit of an advertisement. If you've got some good ideas on measles, rubella, polio, hepatitis B, those are generally the areas we focus on. Our routine immunization in general, please send me an email and let me know your idea because we're very interested in pushing that forward. We're working with some academic institutions developing some new delivery systems for measles and rubella and polio vaccine, microneedles, which essentially are little tiny needles on Band-Aids that you stick on an arm and they dissolve in your skin and you can rip them off after 10 minutes and you're vaccinated. So this is actually something that a person could administer to their self or their child. We're also developing a serologic test which will not only test for one antigen, for example measles, but also things that would have the ability to look at many different diseases. For example, tetanus and diphtheria and hepatitis and rubella. And we're almost there actually, and are pilot testing this product in the field. And I'm up. 15 minutes is up. So I will quickly finish up. This is where we are with global and regional MCV2, that's measles-containing vaccine second dose coverage. You'll see Europe is just under the Western Pacific region. You guys have a way to go, I'd say, before you are there in terms of population immunity to eliminate measles, but you could be doing worse. And finally, here's a chart of how measles cases have declined over time, and some of the recent data on outbreaks that have occurred in your region from, I think, 2009 through 2012. And you'll see that a number of very quote-unquote developed countries are listed there, and I think this represents the vaccine hesitancy that I think you all are very well aware of. Just one last thing I wanted to say, that an important part of surveillance is monitoring the quality, and it's important to be aware that there are performance indicators that tell the program how well they're doing in terms of identifying and reporting diseases. And here are some examples of some surveillance performance indicators. And just in summary, high quality surveillance is needed to identify cases in the virus, eliminate residual areas of transition, and verify elimination when that's appropriate. Standard indicators should be used to monitor surveillance quality. And finally, contact tracing, lab confirmation, very important point, virus detection and determining source of virus are critical to moving your program forward. So thank you very much.